Hello and welcome to the World Economic Forum in Geneva. My name is Adrian Monk, here for this World Health Organization Africa media briefing. We're joined from Brazzaville, Congo by Dr. Matshidiso Moeti and her colleague, Dr. Yao. We're also, I'm delighted to say, joined by ministers from across the continent. And I'm joined here in the studio by my colleague Jan Zopf.
Bonjour, Jan Zopf, responsable média, et je vais animer les questions en français.
Thank you very much, Jan. But first, for our overview on the progress in fighting the pandemic across the continent, can I turn to Dr. Moeti in Brazzaville for the very latest update? Dr. Moeti.
Yes, thank you. So good afternoon to everyone and thank you for connecting with us. Bonjour à tout le monde. Merci d'être avec nous cet après-midi. I'm very pleased to be joined by the Honorable Ministers of Health of Mauritius, Uganda, and South Africa. Welcome, Ministers. I'd like to start by commending your tremendous leadership and through you, appreciate the all-of-government approaches that the heads of state are leading in fighting the COVID-19 pandemic in the African region. I look forward very much to the sharing of experiences and achievements today and going forward, particularly on the progress made in balancing between preventing the spread of the virus and saving lives while protecting livelihoods in response to the COVID-19 pandemic. On the African continent, it took 36 days to reach 1,000 reported cases and then 62 days to move to 100,000 cases. We are just above this 100,000 now. We are seeing some rapid increases. Compared to 2 weeks ago, reported cases have tripled in 5 countries and doubled in 10 countries, noting that most countries still have fewer than 1,000 reported cases. This means that as governments ease lockdowns and other social measures, it's important that the strong public health measures are in place all over the territories, not just in the capital cities, that communities are empowered and enabled to take preventive actions, and that we continue working on strengthening health systems and delivering essential services to people. Yesterday marked 3 months since the first COVID-19 case was reported in sub-Saharan Africa in Nigeria. In this time, governments have been working day and night with support from WHO and our partners to contain the spread of this virus. We've worked with partners to procure and replenish essential supplies and equipment. I have to say that this remains one of the biggest challenges in the response because of disruptions in the global market in items such as test kits and personal protective equipment. We've trained more than 10,000 health workers in Africa as part of the decentralization of the response in areas of intervention like infection prevention and control, management of cases, logistics, and also psychosocial support, which is very important. We've repurposed 900 WHO staff at the regional level and in every country to support the COVID-19 response and mobilize more than 220 international experts to send to our countries to support them. We're also leveraging new tools and ideas, including through the first Africa Hackathon for COVID-19, which brought together 100 innovators and provided seed funding to take forward the most promising proposals, including mobile-driven self-diagnosis, screening and mapping tools, and low-cost methods for producing personal protective equipment. These are a few of WHO's key actions in addition to partner coordination, collecting and analyzing surveillance information, and providing policy and technical guidance to countries on a daily basis. In closing, with strong country leadership and implementation of public and social health measures, cases in Africa remain lower than in some other parts of the world. However, we are not letting our guard down and we cannot be complacent. We all have roles to play and must be ready for a long fight against COVID-19. So I ask that we continue with international solidarity and we maintain a strong focus on preventing the spread of this virus to protect every community. Thank you again for having joined us today.
Dr. Moeti, thank you so much. I want to turn first, if I may, to Dr. Kailesh Jagutpal, who's Minister of Health and Wellness for the government of Mauritius. Doctor, can you explain a little bit about the situation you're facing in Mauritius and perhaps how you've been combating the pandemic?
Thank you. Dr. Moeti, WHO Regional Director for Africa, Dr. Mkhize, Minister of Health of South Africa, Dr. Aceng, Minister of Health of Uganda, Dr. Michel Yao, the WHO Program Manager, members of the press. It gives me great pleasure to take part today in this virtual press conference. Mauritius registered the first cases of COVID-19 in March. Our monitoring and preparedness action plan was in place already since mid of January. The Mauritian Prime Minister himself chairs a high-level committee on a daily basis. This allows the government to have daily updates on the evolution of the pandemic and implementation measures accordingly. The government of Mauritius decided to impose sanitary curfew, which should remain in force till the 1st of June. We are now gradually resuming activities and in a controlled manner. Passengers' flights have been temporarily cancelled, and we are actually in the process of bringing back Mauritian citizens stranded abroad. They are systematically put in quarantine for 14 days upon their arrival, and before they've been discharged, they are doing a PCR test. Our contact tracing exercises has been reinforced, and the testing capacities have allowed us to have a better picture of the evolution of the situation within the community. As of date, we have registered 334 cases, positive cases. We have sadly had 10 deaths, and 322 patients have recovered. We have not had the chance of any positive cases in the local community since more than 1 month. We have, however, registered 2 imported positive cases recently, and those were passengers who have traveled from abroad and they have been in quarantine. So before leaving the quarantine, while doing the test, we have got the positive results. So here a little bit about a broad picture of the Mauritian situation. Thank you very much, Chair.
So thank you for that update. If I may, I'm going to turn to South Africa and Dr. Zweli Mkhize. Dr. Mkhize, can we hear from you on the situation that you're facing now in South Africa?
Thank you very much. Thank you very much, colleagues, and thanks very much to the Regional Director for WHO, Dr. Moeti, the Honorable Dr. Jane Aceng, Minister of Health for Uganda, Honorable Dr. Kailesh Kumar Singh Jagutpal, Minister of Health and Wellness in Mauritius, the Managing Director of the World Economic Forum, panelists, ladies and gentlemen of the media, thank you very much for the opportunity to share our latest development and progress in relation to the fight against COVID-19 in South Africa. We have had our first case on the 5th of March, 2020. At this point, the numbers have increased. We have at this point got about 25,937 of positive cases. And this, we have noticed a change in the pattern because for the first 3 weeks, we had a doubling time of 2 days. We imposed a lockdown, closing up all international travels and international flights, and as the result, stopped all movement. And after that lockdown, we were able to see a reduction in the doubling time to 15 days. And out of that, now we have started easing the lockdown. And as we do so, we do a risk-adjusted approach. We've, however, noticed that there are certain parts of the country where the outbreak has come out in clusters. In particular, that's what has driven the rise at this point of the numbers. And so at this point, our death rate is up to 552 people, which represents about 2% of mortality rate, and recovery is about 13,000, which is just about 52% of all the cases. We have done a number of tests out in the community, and out of that, we have done over 634,000 tests, which represent about 10,000 tests per population. So during this period, we have therefore identified that most of the part of the country is stable, except there are about 13 areas which are districts and metropoles where the epidemic is being driven from. And these we have declared as hotspots, and therefore we have put in the additional restrictions, wherein additional human resources, subdividing the district into sub-districts and the clusters of wards for intensive management by epidemiologists, family practitioners, public health specialists. These are the ways to contain the additional numbers of people who are turning positive. So more isolation of those who are positive, quarantine of those who need to be quarantined. But we're moving forward now to ease for purposes of ensuring that we release social and economic distress. So most of the activities are returning to normal economic activities, but we're insisting now on protocols on distancing. Everybody must wear a mask, including cloth masks for those who are living home, which are homemade as such, and then ensuring that in every place the issue of distancing, reducing congestion have to be looked at. And so we also have increased human resources, including the very welcome support from Cubans. About 217 of them are coming to strengthen our ground teams. So increasing the beds, increasing the ICU beds. At the moment, we've got just about 1,000 people in hospital, with less than 200 of them in ICU. So all in all, we believe that in the future, we're going to be seeing more of these clusters arising in a number of areas as we are returning to normality. And therefore, we hope to contain them as we move. But we do see that the impact of the infection is increasing. We still believe that it will be within the scope of our existing health services to contain. Our major challenges still remain availability of diagnostic kits and PPEs, which are really a constraint all over the world. But nevertheless, working together with the members in the continent, we're trying to look at pool procurement to be able to access more of those. And we want to call upon all those countries where it is possible to manufacture and produce, that there should be equitable access to therapeutic agents and to vaccines, so that we can all deal with the problem of the pandemic equitably across all the countries in the world. Thank you very much.
Thank you very much. And we can go to Uganda now to join the health minister there, Dr. Jane Aceng. Dr. Aceng, can you bring us up to speed on how Uganda has been coping with this pandemic?
Well, it's a pleasure for me to join you today on this virtual press conference. And indeed, it is a privilege for me to speak and share with you on what Uganda is doing. I want to recognize you, Dr. Matshidiso Moeti of the WHO Regional Office, Honorable Dr. Zweli Mkhize, Honorable Minister of Health of South Africa, Honorable Dr. Kailesh Kumar Singh, Minister of Health and Welfare, our moderator, Adrian, I recognize you. Thank you very much all, first of all, for staying safe and staying alive. As you're all aware, at the time that the pandemic was declared, Uganda was responding to the threat of Ebola from the Democratic Republic of Congo. And so this pandemic found Uganda high on alert. And I must say, with the experience that we have had in responding to Ebola, we had some fast run on the ground, which facilitated us to propel ourselves forward. And right from the outset, we have had very strong leadership from His Excellency the President, rallying the whole of government to respond to the COVID pandemic. And so far, the President has addressed the nation 15 times and issued over 36 guidelines on prevention of COVID, including locking down the country so that we can suppress transmission. Initially, our response was based on preventing importation, but once the virus sneaked into the country, we had to change our strategy to suppress transmission, and that brought in the lockdown, the closure of schools, closure of churches, preventing of public transportation, private transportation, and many others. And I must say, this has greatly helped a lot, because then it gave us opportunity to do what the World Health Organization has guided, that once you lock down, then you don't just sit, you need to start to develop capacity in the entire country. We have had a very strong multi-sectoral response under the national task force that is chaired by the Prime Minister, that brings all the sector together to plan together and to roll out the different activities that we have on board at the same time all over the country. We set in place a lot of legislation, plans, and guidelines, including statutory instruments that were adopted from the Public Health Act to help us to enforce some of the presidential directives, which part of the government and that is the law enforcement officers have to enforce in the entire country. We also mobilized our scientists to be able to give advice, and so we have a scientific advisory committee comprising of 16 scientists with different expertise to help us guide the response moving forward. We have also had a lot of collaboration with the academic institutions, and an example is the rapid assessment survey that the scientists carried out in the entire country, and this was to give us quick information as we thought about beginning a phased lifting of the lockdown. Decentralization of the response was pertinent, as many of the returnees from abroad had entered the country and distributed in the entire country. And so we moved in to strengthen the subnational and regional levels in terms of capacity to carry out surveillance effectively, in terms of capacity to treat patients effectively, in terms of capacity to strengthen risk communication down up to the village level, as well as be able to coordinate with us. And so the entire country has what we call district task forces in every district that coordinates directly with the center. We have also embraced a number of ICT solutions for us to track our people who test positive. We have emphasized a lot on local production. We have personal protective wear, the hand sanitizers, the ventilators, tents, and including other medicines being produced locally currently in the country so that we can quickly have these items available. Our scientists have also moved in to start production of rapid test kits, including other test kits for antigen testing, so that they can boost us wherever we lack capacity. We have also noticed an essential medical services that we are strengthening, as well as community engagement.
Dr. Aceng, can I just ask, we have a first question directed to you from Pamela Mwanda of the Uganda Radio Network in Kampala. And she's asking, Uganda has yet to report any COVID-19 deaths. And she asks, why is that? Could you give us a brief answer to that question?
Confirmed cases. We have discharged a total of 69, and we have 217 active cases. Now, because of the relatively small numbers, it gives opportunity to the health workers to focus more on the patients and treat them well. In addition, our scientists are relatively flexible. And apart from focusing on COVID-19, they focus on the whole of the patient and address the needs of the patients directly. So that gives opportunity for us to understand the patients one by one and to treat them. We have over 16 treatment centers in the country, as I mentioned earlier, and with 16 treatment centers and close observation, that helps us to focus on the whole of the patient.
Thank you so much, Doctor. I'm going to turn to our first live question to Marcia Zali of Health News in Johannesburg, South Africa. Marcia, can I come to you for your question, please?
Thank you for having me. So my question is directed to Minister Zweli Mkhize. There was an announcement that since we are moving to level 3 of the lockdown, churches will also be allowed to operate. So I'd just like to find out what inspired or what was that decision based on, seeing that countries like Germany saw an increase or more spread of the virus coming from church services.
Thanks for that. Dr. Mkhize.
Thank you very much for the question. I should indicate that the response to the COVID-19 in the country is led by the president, who meets with, together with other ministers who meet various players in the sectors, various sectors in the country. So there's been lots of consultations with the business community, religious community, traditional leaders, civil society, and various political parties. At the end of the day, it has become clear that we are likely to have this pandemic for more than a year to maybe even to 2 years. And therefore, it is important for us to understand that there is a degree of easing that has to be brought into the approach. So the president has called on what we call a differentiated approach and a risk-adjusted easing of the restrictions. And in this process is to begin to motivate for every part of our society to focus on social and behavioral change. And therefore, part of what has to be done now as the movement is to emphasize on behavioral change, the use of masks, hand sanitation, distancing on all the sectors in our country. And therefore, we have now charged all sectors with the responsibility of teaching their own constituencies and their own members on this issue of behavioral change. So in this case, the consultation with the churches has indicated their willingness to start changing their conduct in terms of how they conduct the church services, increasing the distances between the various individuals in the church, and also to restrict the numbers to the 50 that we had just before the lockdown was announced. And therefore, we are giving every aspect of our society an opportunity to start implementing behavioral change approaches so that we can slowly ease into the future. When we get the schools preparing to open and factories and various mines trying to open, we need to now say to everyone, whether they remain open or closed is going to depend on whether they're able to focus on the restrictions that have been put into into place. We do understand it's going to be a big challenge. We also do understand that we can't hold the country in a lockdown forever. We also understand that economic activities have to be resumed, that relief of hunger, relief of social distress has to be focused on as well. So this is the approach that has been taken in consultation with the various stakeholders and the leaders of those various stakeholders in the country. Thank you.
Thank you very much, Minister. Turning to Elizabeth Merab from the Nation Media Group in Kenya for her question. Elizabeth.
Good afternoon. I have two questions with regards to the situation in East Africa. When you look at Rwanda and Uganda, they've not recorded any deaths so far from their 339 and 367 cases respectively. And when you go to Rwanda, it seems the country seems to record a very high recovery rate. What are these two East African countries doing that is giving them these better outcomes compared to their neighbors like Kenya, which have cases to the tune of 1,471 and 55 deaths? Also, I'd like to find out how far we've gone with regards to the genome sequence activities that are happening in Africa. Have they been completed, and what is the analysis so far? Thank you.
Thank you very much. Thank you very much. And perhaps we can turn to Dr. Moeti first to address those questions. Is there something specific about the countries mentioned in their approach that perhaps gives pointers to other countries facing this pandemic? Or is their relative success still something of a mystery? Dr. Moeti.
Yes, thank you very much for that question. Well, perhaps Minister Jane Aceng can also supplement. I think she gave an overview of what's happening in Uganda. One of the things that we can say is that these are countries whose health systems, if you look at performance, were already performing relatively well. If we look at the index that WHO has developed to look at health systems performance, Uganda, Rwanda are among the best performing in terms of coverage, in terms of quality, in terms of the various elements of a performing health system. Secondly, these are countries that are surrounding the DRC, in which a great deal of effort had already been invested in preparedness for outbreaks in the context of the Ebola outbreak. So I can say that it very much depends on the already established capacity of a healthcare system in a country, how treatment is done. And I think these are among, if you look at our index, these are among the best performing countries as far as health systems are concerned. I think most countries are taking the same approach in terms of how to identify, how to manage, how to treat patients. Some have invested a lot more in scaling up their capacity, carrying on training of their healthcare workers, and enabling the quality of treatment to be up to the mark. It also might be depending on the background in terms of the profile of the people who are infected and fall ill. So the more you might have of some of the pre-existing conditions like cardiovascular diseases, obesity, then the more difficult might be the outcomes in terms of treatment. I think in terms of gene sequencing going on, we know that there are a number of laboratories that are doing this in African countries, and I think their findings are similar to what has been found internationally. And really, we do not have identified within Africa strains of the virus that might make a difference in terms of either the virulence or the infectivity of the virus. What is being revealed at the global level through some work that's been done by some Chinese scientists and in other countries, that apparently the possibly two strains, the so-called L and S strains of the virus, and the L strain is found to be the one that's the more virulent, causing in some countries a higher proportion of deaths. So we will be seeing with our scientists if we can look specifically around these types of differentiation and predict what might be the impact in terms of outcomes when people are infected.
Thank you. Perhaps we can turn just briefly, Dr. Aceng, to you, just to for more insight into the way that you, as you previously described, have been tackling this pandemic.
Well, thank you very much. And again, I want to appreciate what Dr. Moeti has just said. But like I said before when I was opening, Uganda has had opportunity to have several outbreaks. From the year 2000 to date, at least we have had over 6 Ebola outbreaks and about 5 Marburg outbreaks and several other outbreaks. And these outbreaks have given us opportunity to build capacity, but also to build systems in place which can easily be activated to respond to epidemics as they are occurring. And like I mentioned before, that gave us a first-hand propelling into handling the COVID pandemic as it came on board. So many other countries surrounding us have not had that experience, but I must say the DRC has also had experience in handling this pandemic. But over the years, Uganda has been building capacity in terms of human resources, in terms of a well-functioning public health institute, an emergency operations center, and rolling out the system to the entire country so that we are able to visualize what happens in the entire country on a daily basis. So that speaks to what is happening in Uganda, that we are able to identify, take quick decisions, and respond immediately. Thank you.
Thank you very much. Yeah.
On a aussi des questions en français. On a une question de Falila Gbadmassi de France Info Afrique. Que dit l'OMS aux pays qui ont déjà déclaré qu'elles continueraient d'utiliser la chloroquine? Question à l'OMS. Combien de pays africains participent aujourd'hui à l'essai de solidarité? Je pense peut-être Dr Yao pour nous éclairer là-dessus et peut-être aussi Dr Moeti.
Merci beaucoup. En ce qui concerne la chloroquine, je pense que l'OMS a clairement émis des recommandations par rapport aux résultats obtenus au niveau de solidarité trial et donc les recommandations sont assez claires. Et donc, ce sont des recommandations adressées aux pays. Nous savons que certains pays ne faisaient pas partie de cet essai clinique de solidarité. Ils avaient déjà entrepris des protocoles. Ce qu'on préconise, c'est qu'il faut absolument que cela se fasse selon les standards éthiques avec l'approbation des différents comités scientifiques. Et nous pensons que ces comités tiendront compte probablement des recommandations de l'OMS sur ces évidences qui commencent à être beaucoup plus solides avec le nombre de personnes qui ont participé à cet essai-là. En ce qui concerne pardon, le deuxième volet de la question, c'était, pardon?
C'était combien de pays africains participent aujourd'hui à l'essai Solidarité?
À l'essai Solidarité, malheureusement, il y avait 28 candidats, mais les processus qui étaient en cours n'ont pas permis. Il y a seulement l'Afrique du Sud qui avait finalisé le processus. Mais je ne pense pas qu'ils aient pu recruter des patients lorsque tout le processus était terminé. Mais il y a plusieurs pays qui, de façon interne, en dehors de l'essai clinique Solidarité, avaient déjà commencé des protocoles à l'interne. Merci.
Merci beaucoup.
Thank you very much. I want to turn, if I can, to Asamu Nakahi of Kyodo News, who's based out of Nairobi in Kenya, for his question. Nakahi-san. No, he appears to have dropped off the line, which is a shame. But I do have his question here, which is, as a majority of the African population is young, does this reduce the risk in the current pandemic? Perhaps we can turn to our health ministers to address that, and perhaps we can go to Mauritius and to Minister Jagutpal. Is population Minister, a factor, do you think, in perhaps why some African countries have not been so badly hit?
Thank you very much. First of all, I must say that from our analysis, our average age group is about 33 years. So that does clearly indicate that even the younger age group can be affected by COVID-19, and they are also prone to succumbing if not well taken care of and not well educated about COVID. We have not been seeing many of the older age groups, perhaps because we instituted measures to handle this quite early. But also because our numbers are low, we cannot exactly give you very clear statistics, but from the small analysis that has come on board, our average age group is 33 years old.
Thanks very much, Minister. And there's a question along similar lines, I think, from Gabriella Steinhauser of the Wall Street Journal from Johannesburg in South Africa. Gabriella, can I get your question?
Hi, thanks. We've seen in a few poorer countries that the people dying from COVID tend to be younger than in the richer countries. So, for instance, in South Africa, I think of the recorded deaths so far are under the age of 50. Is that something that you're seeing across Africa? And if so, do you have an explanation for that? Is it just a different group of people who are getting sick? Or are there other?
We just lost your line there for a moment, Gabriella. I'll put that to Dr. Moeti in a second, but perhaps we could get Minister Mkhize just to give us a little more background, perhaps on the age profile of the victims in South Africa, and also perhaps, given our previous question, just to say, has that population age profile had any impact on how the pandemic has been felt? Dr. Mkhize.
Thank you very much. I think the pattern of mortality is something that in our case has been evolving. We didn't have any mortality for the first 3 weeks. And at that time, we had a number of positive, were about 930. But after that, we have seen that the numbers have increased. Of the current numbers, we have about 550. The 50% of those happened in the past 2 or so weeks. Now, if you look at the profile of the patients, we've got very few patients who are below 20 years, very few that level, but from 20 to 50, that's where the large majority of the people are. But the mortality starts rising from 50 to 59, 60 to 69 and above. So we believe that that side mortality tends to be driven by age and comorbidities, which tend to be a factor right across. So as we look at the outbreak, we think that there's a large number of people who are asymptomatic, and those tend to be younger people who tend to do better in terms of the recovery from the infection. And those who tend to be more susceptible are those who have got both comorbidities and also progressing age. So I would say that the large numbers that we are seeing are actually from 50 to and above 50, largely 50 to 59, 60 to 69 and above. That's really the pattern that we're seeing. Thank you.
Thank you. And Dr. Moeti, as you look at the figures across the continent, is your observation that age is a factor in the progress of this pandemic?
Well, yes. I think, first of all, two things. In terms of those who are infected, younger people tend to be the majority of those who are infected, people between the ages of about 25 up to about 45 Yes, we have observed that among the people who are severely ill and who die tend to be concentrated in the older age groups. If we look overall over the region of people over the age of 60, I must say that if one is looking at comorbidities in Africa in general, we've observed in our data on non-communicable diseases, for example, so cardiovascular diseases, hypertension, and even things like obesity, that African people in general tend to be affected earlier and tend to be more seriously affected, and in fact tend to die earlier of these non-communicable diseases, which constitute the majority of these comorbidities. So I think we would need to look at those factors as well. But overall, our observation is that looking overall at the region, we are seeing more people dying disproportionately in the older age groups, although we are seeing a larger proportion of the infected people being among those who are younger.
Thank you. Wondering if we can go to Chris Giles from the BBC in London, and also to Undumiso Mlilo in Johannesburg. Just wondering if we can go to Chris Giles first. No, we don't have Chris Giles. Do we have Undumiso Mlilo from Johannesburg with Xinhua? Just checking to see if he's on the line. No, neither of those. There are two questions, though, from both the BBC and also from Xinhua News. The first question, what's the WHO's current assessment of the coronavirus situation in Tanzania? Second question is from Xinhua, is what's your view on Madagascar's proposed treatment? Dr. Moeti, perhaps I can put those back to you.
Okay, thank you very much. Well, as far as the situation in Tanzania is concerned, we have had reported to WHO 509 confirmed cases and 21 deaths so far, of which the majority, 375 of the cases are on the mainland and 134 are on Zanzibar. The last time Tanzania reported a confirmed case was on the 29th of April, which is almost a month ago now. And from Zanzibar, the last case was reported on the 7th of May. So this is what we know of the situation in terms of the number of cases. In the past, we have had information shared with our country office on the situation around the country, the distribution of these cases. We are aware that the country has implemented some of certainly the core public health interventions of tracing contracts are being implemented in Tanzania. Some of the public health and social measures are also being implemented. Schools were closed, along with gatherings like trainings and seminars, large social gatherings like weddings. We are aware that markets and religious gatherings are still ongoing, but that these have been requested to be carried out implementing physical distancing and hand hygiene. So our sense is that some measures are being implemented in Tanzania. Our country office is involved in various technical committees that are advising the Ministry of Health and also very much in coordinating the work of the donors and partners in this country. So this is the information that we have so far of the situation in Tanzania. It is some time since the last cases were reported to WHO from that country.
Thanks. And regarding the Madagascar question from Xinhua on that treatment?
Okay, the Madagascar question. I mean, here we have, we are continuing to be in dialogue with the government of Madagascar. We have reached an agreement in conversation with them that WHO and also the Africa CDC are going to help them in finalizing the development of a protocol on how to assess the efficacy and the side effects of the COVID organics. We are also proposing and reaching out to the other countries that have had access to this product to see if we can organize a multi-center study with them. So our discussions with them is progressing. We are going to be working together with other partners on how to assess what is happening, or at least how to help in the design, put in place a technical group of African scientists who are very experienced in carrying out clinical trials, and also start to mobilize and sensitize the regulatory bodies of the countries concerned, because at the end they will also have to be involved in the conclusions of their countries on this trial. So we are engaged with the government now in designing how to assess the COVID organics product.
Thank you. Go briefly now to Takeshi Ishihara of Asahi Shimbun in Johannesburg, South Africa. Ishihara-san, your question.
Okay, thank you very much. Can you hear me?
Yep.
Okay, thank you for having the precious time. My name is Takashi, a Japanese journalist based in Johannesburg. I have two questions to the Minister of Health of South Africa, Dr. Mkhize. I think all the peoples in South Africa is concerned about the situation of Cape Town. So what makes Cape Town or Western Capes the biggest hotspot in South Africa and Africa? And the second question is about the statistics. If my understanding is right, South African government does not show the number of cases and the victims by race, while New York City is showing the racial breakdown of coronavirus victims. So which races are more infected and more vulnerable in South Africa? Thank you.
Both those questions for Dr. Mkhize. Dr. Mkhize.
Thank you very much for the question. Let's deal with the last question. We have not released any statistics based on race. That issue is being raised now by some of the political parties. There's not really been a need for that up to now. What we can say is that the nature of the pandemic over the past few weeks has evolved from a group of people who are more likely to be travelers. And so we're dealing with imported cases. People who are linked to tourism, to the Western countries in particular. Now, after the lockdown, we closed the international travel. And so we ended up with more of the internal transmission. The majority of people who are affected would probably be, would obviously be the Black African community, mainly because of the rate of spread is actually higher in areas which are densely populated. We haven't got the exact numbers that we have published, and that is something that we will discuss, and at some point we can bring it up when necessary. All we can say is that when we look at what has happened in the New York and the United States situation, it is very clear that the racial distribution or the racial profile of the deaths seem to be linked largely to the question of access to health services. And we believe that's a very major factor in this case. And the factor has got more to do with the health services and their ability to be able to support those who ultimately fall sick and end up in the hospitals. And as a result, when we are approaching our situation, we felt it was important to bolster our health services response in terms of the numbers of health workers that we employ, additional ones, and we also employ, create additional beds to be able to accommodate and treat those that get affected, as well as ensure that we've got protocols so that everyone has got an ability to manage these cases in a uniform way. And we believe that it's a very, very important intervention, apart from the containment measures of taking people for quarantine, as well as isolation in the hospital. Having said so, I want to then focus on the Western Cape situation. Now, in the Western Cape situation, this province was the third in terms of the numbers of patients at the beginning. It moved on to become the second, and then of course right now 2/3 almost of all the positive cases in South Africa are coming from this population, which is really roughly about under 15% of the population. Obviously something here is driving the pandemic, and so having looked at it, we found that at the time of the lockdown there were a number of areas where it seems the infection spread pretty fast, and these were cluster outbreaks that were found in retail shops, in factories, in food processing plants. Unfortunately, those areas were areas which had been exempted from the lockdown, so people were expected to be doing work at that level. It is clear as well that at that time, containment measures had not been very strictly adhered to, and therefore we found, by the time they were found, there were clusters of outbreaks, and those people actually were associated with different villages, townships, and suburbs where they came from, and so the infection spread quite fast in the community before they were even found and they were discovered. So we now have to catch up with the numbers of positive cases, as well as ensuring that those who are associated as contacts can be quarantined. That is why now we've put up additional reinforcement of health experts into sub-districts so that we can manage the issue at a smaller location, geographic location, in a cluster of wards, and that is the strategy that we have embarked upon to deal with it. It is a matter that is giving us concern, but also it's a matter that's indicating to us that if we find the solution to slow down the infection there, we'll then use that to deal with the other provinces, because it's already showed a spill over to the nearby province of the Eastern Cape, which is adjacent there too. And then with the easing of the restrictions, this might spread to more areas. We've already seen some of the outbreaks showing out in the mines in areas which had very low transmission, such as the Northwest Province and Limpopo. So this is the pattern that we think is going to be taken by the turn of the infection. So we've declared about 13 districts as hotspots for intensive interventions and for additional restrictions to try and contain the spread of the infection. Thank you.
Thank you, Minister. I want to turn briefly to Vinicius Assis from South Africa for his question, and perhaps also we can take Cara Anna's question from Associated Press. Vinicius.
Hello. Good afternoon.
Go ahead.
What is the main challenge to increase the number of tests in African countries? And if you permit me, I would like to ask two questions. Which African countries are WHO most concerned about, and why? Thank you. Thank you.
Testing and concern. And Cara, can we get your question as well?
Yes, just asking, what is the latest on the availability of testing kits and reagents? How will that change in the coming weeks? And how soon will their production by African countries show results?
Thanks for that. And I might turn first to our ministers before going to Dr. Moeti on that, and just ask, perhaps we can start with Dr. Jagutpal on the testing issue. How are you with the availability of tests and the ability to produce them, Doctor?
Yes, thank you very much for these questions. Now, we have two types of tests. We have the PCR test that is being done. There is a procedures in that. And also we have the rapid test. Now, the rapid test, we have different companies throughout the world who have developed those tests. And now it's up to countries to decide which one they're going to take. Now, we also know about the reliability of the test, be it the rapid test and the PCR test. Now, I believe now at this stage, when the pandemic is progressing, and now where countries have to go through the lockdown period and to start reopening in a gradual way, it's a very important step to do the testing, because the testing will allow us to understand how is the virus in the community. There's another test, the antibodies test, that also we have to take into consideration, because if the virus is already in the community and now we have a population that has already got the immunity, has already have the antibodies, this has also to be considered so that we know in which direction we are moving. Now, about the testing capacity, it's up to the different setup of the medical setup or the health setup of different countries to see. I'll just give you the example of Mauritius. In the beginning, for a population of 1 million people, we had only one test, one PCR machine. With the efforts, we have been able to mobilize 3 PCR machines, and that has escalated our capacity of doing around 100 PCR tests daily. At the same time, the government has also given private companies, private laboratories to start doing the tests. On the other side, we have imported tests from South Korea, and we start doing the rapid test. We started by doing it for the frontliners, for the health workers, for the police, and gradually we have done it for so many frontliners who have been very active even during the curfew period. So that's how I believe we should carry on with those activities so that in the future we'll have a better idea, we'll have a better knowledge about the testing in terms of testing capacities for new cases, but at the same time, without forgetting that we have to also have the antibodies test to know how far the virus has entered the community. Thank you very much.
Thanks so much, Minister. I want to make sure we can get to all our ministers and to Dr. Moeti before we close out today's press briefing. Dr. Aceng, can I just turn to you and ask how concerned or how well prepared you are in regards to testing and testing kits in Uganda?
Well, thank you very much. As you're all aware, access to test kits is a big challenge for all of us. And to date, Uganda has tested 1,113, 421 tests. Amidst all the challenges, we are still using the PCR test. We have not started on any rapid diagnostic tests. We are accessing test kits through a variety of sources, including through partners, the WHO, the Clinton Health Access Initiative, Global Fund, and others, and also directly by government procuring the test kits. The test kits obviously come in small ratios, which is a bit of a big challenge to us because we would want to be doing more tests than we are doing now. And as the pandemic evolves and we have challenges of cross-border truck drivers, it becomes even much more necessary. And so in a bid to address this, government is also supporting its scientists to develop the rapid test kits that we are currently validating in the country. Obviously, it is a bit of a challenge, but I must say our scientists have done a good job. And right now we are doing some validations, running it alongside the PCR tests to see their performance and whether they would present something useful as we progress with the first lifting of the lockdown. We would like to have many more tests in the country, and I want to believe that the consortium that has been set up by the World Health Organization will be addressing this. My humble appeal is that it is not addressed based on the burden of the pandemic, but on the necessity that the country presents. I thank you.
Thank you so much, Minister. And turning finally to Dr. Mkhize in South Africa, what's your perspective in South Africa on the availability of testing and the kits that you have there?
Well, there's no doubt that Africa as a continent needs to have its own internal capacity to produce diagnostic kits, and this matter is being discussed at various levels. In South Africa, there are some initiatives through our CSIR to look at possibilities of producing such diagnostic sets, but at the same time, we believe that in the short term, working together as the Africa CDC and the entire continent, we need to look at pooling all our needs so that our procurement, so that we can actually benefit from large volumes, because we need several millions of these kits into the continent, and a lot of work is being done to reach out to many of the manufacturers throughout the world. In South Africa, we have a number of laboratories which are performing tests throughout the country, and at the moment, as I've indicated, we've done over 436,000 tests, and we believe that the continent needs more, South Africa needs more, everyone needs more, and we have then reached out to license over 20 additional diagnostic kits which are either awaiting validation inside the country or are being delayed by the global shortages thereon. Those are the PCR tests. And then on the side of the serological tests, which are mainly antibody tests, the rapid test kits, here we've approved 5 of them and licensed them. They are going through validation. And so the real issue for us is to be able to reach out to the manufacturers and ensure that the distribution of the diagnostic kits is equitable right across those countries that need it, not only those countries that host the manufacturing companies, and not only those that are better resourced. And I think it's important for us, not only on the issue of diagnostic sets, but also in the issue of therapeutic agents, the new that are under trial. When they become successful, the whole continent needs to be given equitable access, as well as the vaccine. The vaccines as well need a similar situation. And if there's a way, we need to also look at how the continent must have its own capabilities of being able to produce and develop more vaccines for its own, for use within the continent, so that the issues of sustainability can be addressed. Thank you.
Minister, thank you so much. We're out of time, but I think it's just a moment to bring in Dr. Moeti, really just to conclude on that issue of testing kit availability, and also that final question about, are there parts of the continent where you're worried about the growth of cases, perhaps? Dr. Moeti.
Yes, thank you very much. As I said at the beginning, indeed, access to test kits and therefore the rate of testing is one of the biggest challenges that countries in the region are facing at the moment. So I can only echo what the ministers have said. Some of the countries that are testing the most are, for example, Mauritius, the Seychelles, South Africa, which are testing at about some 200 per 10,000 people. South Africa is at 112 or so. We've also seen testing capacity expanded beyond central level capital cities out to the provinces and districts in a number of countries. South Africa has done that very much so, Ghana and Senegal as well. WHO, as was mentioned by the Minister Jane Aceng, is working at the global level. We have a global consortium of partners where there is an effort to benefit from economies of scale, buying for all the countries in the world, including African countries, and therefore get attractive competitive pricing for these items. And our role as the representatives of the African region is WHO is very much to advocate and to work with the group that's working on criteria for allocation to ensure that the countries of our region are not disadvantaged in the allocation decisions because they simply have fewer cases. And this is something that we are in a discussion with our colleagues on. There's been a strong recognition of the challenges that African countries face, including the weakness of our health systems to deal with severe cases. So I think this equity question is very much going to be taken into account. We've also had discussions. I was talking to Dr. John Kengasong of the Africa CDC a couple of days ago of how to team up and link what we are doing on this procurement so that we are not competing on the international market, but we are supplementing each other and working as far as we are concerned in the African region to ensure that our countries have access to equitably to these items that are being sold on the global market. Thank you.
Thank you so much. We're out of time on this briefing, but I just want to give a big thank you to our ministers, Minister Aceng in Uganda, Minister Jagutpal in Mauritius, and to Minister Mkhize in South Africa, all of them medical doctors, and also to our World Health Organization doctors, Drs Moeti and Dr Yao, for joining with us today. Also, thanks to all of you for your questions. Thanks to my colleague, Jan Zopf, and I hope you'll be able to join us for the next briefing. Thank you very much from Geneva, and goodbye.